Welcome to Karibu Anawim's 15 Minutes at Dr. Zali's Desk special. Join us as we dive into the topics related to living with a facial disfigurement. Whether you're here for yourself, your loved ones, or for educational and professional insights, this is for you. We start our conversation with clear, understandable terminology. While we use disfigurement, it's for medical and legal clarity. We acknowledge you may relate to terms like visible difference or your own diagnoses. All our presenters have lived experience or work with people living with facial disfigurement. Curious to know more? So are we. Pull up a seat, grab a cuppa, and let's chat around the table with Karibu Anawim's 15 Minutes at Dr. Zali's Desk special.
Hi guys, this is Dr. Zali again.
Welcome to Karibu Anawim's 15 Minutes at Dr. Zali's Desk
on.
special. Join us as we dive into the topics.
How rude! I thought I had it all done, and I was like, oh, so clever, but it wasn't so clever. Okay, this is part 2 of Dr. Lowe, interviewing with Dr. Lowe, who's a cancer oncologist and loves reconstructive surgery with a special interest in head and neck cancer patients with facial nerve disorder. So without any ado, I will welcome Dr. Lowe back. Hang on, once I get the cursor down where I need to bring him in. And hello.
Hello, Zali. How are you?
Oh, good. Oh, dear me. That was embarrassing. Gosh, he can listen, and I think he was cracking up laughing, but I couldn't really see because...
You've done really well with the technology.
I try. So last time we left off with, we chatted about what sorts of challenges what challenges do your patients face, and what do you think is the most important, or is most important in the surgeon patient relationship? And you said good listening skills. I'm paraphrasing here. Good listening skills for their worries and concerns. You took us along a journey of what's it like with a cancer diagnosis right through to reconstruction. And now I'm going to ask you, what is a personal high or low that you would like to tell us about, whether or not it's a personal one or a professional one, or maybe both?
I think there are multiple high and multiple lows. I think again, the life is a journey. So there's a lot of high as you go along the journey. So getting to medical school is a high. Getting on a surgical program is a high. Then being able to come back to the mentor that inspired me to do head and neck surgery to an institution that is named after him, that is a high. And there are multiple high, and with the academic career, there'll be, every time you have good publication coming through, you found a good results, you was able to sort out a solution for a patient. Those are many highs that we have. And I think there will be just through the whole journey, there will be multiple highs. It can be 3 highs in a day, or could be 1 high of the month, depending on which time of the year it is.
Yes.
And with the high comes with the lows.
Yeah.
The work that you put in, the effort in, you didn't get the result you wanted. Some of the patient you spend a lot of effort in, and unfortunately the cancer outbeat you. And those are little lows that you have, but with the little lows there are a lot of highs that keep us going.
Yeah. So can you share with us the difference between a good medical outcome versus what the patient thinks that you can actually achieve, their own personal patient outcome, for instance?
So the question referred to a good medical outcome versus a substandard medical outcome? Is it?
No, a patient outcome. So what I mean by that is there's a difference between what you as a surgeon would classify as a very good outcome as opposed to the patient's expectations of your handiwork. So how do you mitigate that? How do you manage those sort of, sometimes it'll be, oh, you beauty, you've done such a wonderful job. You've done outstanding, you've done above and beyond what, if I'm thinking of me being a patient now, above and beyond what I could ever dream or hope for or thought you could do, as opposed to some patients have an expectation of what they think that you're going to get, and it drops. It's not it's not good. So can you talk to us about that?
Yeah, so there, I'm going to break it down into the oncology side and the reconstructive side. I think there are two different conversations with patients. With oncology, when we first met the patient, we will look at how advanced the disease is, how bad the disease is, and what sort of diagnosis they have, and talk to them about a prognosis. I think that's the time that you actually manage the expectation that we can't cure every single patient. But again, as I mentioned last interview, we can bring them through a journey that is positive. And I think those conversations need to happen. That will happen very early on with the cancer treatment. And so that along the way, there will be multiple little outcomes. So there are cancer where patient will have a recurrent, and then we then need to have a conversation about how you manage recurrent to achieve a disease-free status. And so the conversation need to happen throughout the entire journey. That's where the surveillance comes in, where you don't just look at the scan, say you're disease-free, off you go. We will do the imaging. You will say, look, they're disease-free at the moment, and we'll then mitigate what the expectation are, where we think the risks are, and these are the things that we'll need to talk them through, so that throughout the entire journey, we might think that the risk is very low, and we'll be upfront with them so that they know how to set the expectation. And I think it's important that they know what the expectation, because there's some patients that might be worried about planning way forward in future for them, either traveling or their career. Whereas if you know that their risk is very low, we will encourage them to push that forward planning, and vice versa. And in reconstruction, it is a slightly difficult sort of conversation. There will be expectations, so there'll be functional expectation, and what we think was very essential. So we will negotiate those conversations very upfront. Some patients will say, look, this is not important, but you know that if they might not know that this is going to be very important in 2 or 3 years' time. And we will negotiate that. We will start the conversation and tell them what are the things that we expect. And throughout we will have,
So functional versus cosmetic.
Functional versus cosmetic. Let me give you an example. So for someone with a larynx cancer, they're going to lose their voice box.
Yes.
And in some patients that become a no, and they just basically shut everything off. And we don't want that. We wanted to at least talk them through initially the oncology side, and then what we can do in the rehabilitation side. And there are ways that we can reconstruct, say, a speaking valve or a little artificial speech for them. And there are times that we delay that, and we say, look, we're going to. There are times that we say we'll do that when we take the larynx out, and there are times that we say, look, we want to wait a little bit, and we need to then spell out the rationale behind, so that the journey is a positive one. I think those are the things that you want to manage the expectation.
Why would you not do it at the time? Why would you wait to
The risk.
that
So
direction?
every time we do that, we introduce a risk of what they call salivary leak. So a communication from the food pipe into the windpipe, and that can be disastrous. So in some patients, when we know that their healing is not going to be as good, we wanted to delay that. And what you wanted to make them understand is that if we don't let them heal well, they might not be able to go home where we wanted them to. So then that is actually, in our mind, a decrease in quality of life. Whereas if I can get them to heal well, they can go home. We are other ways. There's a artificial vox called vox box we can do. They can translate a vibration in the throat into words. So we can use those tools in the meantime to get them functionally adequate before we then come back to then give a little bit more of the voice for them.
Okay.
So those are the expectations. And the same thing with facial nerve. We will tell them which are the one that we needed to do upfront to get them back functionally, and which are the ones come in a bit later on when we know that the risk of the disease coming back is low, because those then will require a slightly different approach.
Okay. Thank you. So I've got a few questions now from I went out I went out into my little world and I said, if I was going to interview a surgeon, what would the questions be? And some of them were a bit smart-assy sort of thing.
Okay.
Good on you. Yet I've kind of like pulled them back a bit and made it as general as I can. So with a bit of attitude now, I'm going to speak to them and I'm going to say to them, as I say, so why don't you just tell us everything? You know, why don't you just tell us? You know, why don't you just tell us the whole story all at once, up front? Go.
It's sometimes, so I'm going to come back to a patient that I recently treated. She has a deep lobe parotid tumor involving the facial nerve. So to remove that tumor, and she's going to have good, excellent prognosis if we can get the removal done properly. She will lose the conductive part of the hearing. So there's still hearing in her ear, but she'll lose the ability for the sound to come into the eardrum. So she will have what I call a conductive hearing loss. So as though you hear people with the earplug in the ear. She will lose the facial nerve, and then she will have.
So will she be able to smile? Because
not initially.
Okay.
So we will then need to. So that is removing the tumor, and when we rehabilitate her, when we reconstruct her, first of all, we need to make sure that she can heal and she can then have the ability to receive radiotherapy. So you want to reconstruct them in the way that the tissue is healthy enough that when radiotherapy is given to the patient, they're not going to struggle, they're not going to scar down, they're not going to sort of contract. Then we also need to get some foundation for facial nerve in. So getting the nerve connected, getting the face into a position that it doesn't droop and become functional, able to let her eye close. So when we have this patient, if I were to tell, we will have a few consults prior to the surgery to walk her through what are the risks involved with taking this tumor out, and then the second part would be what are the functional outcomes that she will potentially lose, and how are the strategy that we're going to get it back for her. Now she's very smart. Her partner is a medical person. She's a scientist, work in the hospital. So she has a lot of medical background. But even with her, I will say, look, I will give you the information up to your saturation point. At some point, you're going to feel that it's going to be hard to filter through the information. And we will maybe then stop that conversation, let you digest them, come back up again. But we will also need to know that this cancer doesn't wait.
No, it doesn't.
It doesn't wait.
How do you, can I pause you there? How do you know, like you've said that this person is intelligent, she's got the understanding, yet you're, you know, and she can get it on the head knowledge, yeah? She gets it on the head knowledge. However, you've just said a saturation point. So how do you see, not just her, just say someone else that doesn't have a medical outcome or background, should I say, how do you then, as a surgeon, see when people are coming to their saturation points, and how do you judge that?
It counts with experience. I think like all surgeons, when they first started, they just throw everything off to the patient to the point that the patient gets so confused. So rather than say how I judge it, I just say how I approach it to start with. I'll give them a broad outline about the journey on that sort of very specific time point, and then the journey of what I think the tumor is like. And that will be the very broad conversation at the start, and then I'll come back. So this is that sort of circular knowledge. You give them the broad, and then you come back and you fill in the gap. And as I fill in the gap, you will judge by what the patient, you know, when the patient started to look blank, you will ask them what you understand. And if the understanding started to doesn't make sense. So when you got too much information in there in the one go, even with those patients that is very intelligent, they started to confuse about, should I do this? Should I not do this? Why do you want to do this? Can I not do this? And those things that she asked me not to do will compromise the tumor care. And that's a wrong thing to do. Then you have to then unwind back. So look, okay, let's come back a little bit. And just clarify this component, and we say, look, I think we reached a saturation point. We need to have spend another time. So we'll then talk through the next component. But as I said, the cancer doesn't wait, and so what it means is that conversation, we always give them a date for the surgery. So once we did it, so look, we'll give you where the surgery date is, so we know what our timeline is. And we can then fill in those conversations. And some patient will say, look, I just want you to tell me the bare minimum, what's the journey I'm going to be experiencing? And that's all I want to know, because we have built enough rapport that they trust me that I will do what is good for them. Now, some patients like to have a lot more autonomy in this discussion, and we will go through a lot more conversation. And sometimes it's important because they might want me to reconstruct things in a certain way. And we will then talk about the pros and cons about reconstructing in that way. And then if I feel like the patient understood what they wanted and they're happy to accept my explanation of what I think, why I want to reconstruct in a way, but I might go with their way, because they understood exactly what they wanted, and they understood what is important in this conversation and this reconstruction.
Okay. Now do you want to go back to the lady, or would like the last question?
I think the lady was just an example of what we do, and I did this sort of more sort of coming back to the topic and build in more detail as we go. And with her, she, up to a certain point, she said, look, I think I know enough. Please proceed with the surgery. And there was about a day or two before the surgery. That's where we came to that sort of to that realization point that this is, I'm happy to go ahead.
So what happens when I walk away and feel like surgeons, are only seeing me as something to fix rather than a human with feelings and a being that actually has to live with your handiwork? I'm saying it with attitude.
This is how one. I mean,
how they do it.
It depends on how we approach the clinical scenario. I certainly when I went through my training, there are surgeons that said, "This is how I do it. You do not question me." I think time has changed, and those sort of approaches are very very old school, and they I think those in those times the surgeon doesn't like to be challenged, and I think they probably felt a bit threatened when there's been challenged with question. I think time has changed. The internet has changed things. People now getting information a lot more easily. In fact, most patients are information overload through the internet, and they just aren't able to filter things. So a lot of time, our role now is to have the discussion and with the patient about what the expectation is and what we can do, because they know a lot of things through internet. They'll come into the consult having read all the paper that either I've written or I'm reading, but their interpretation is the issue, where they don't know the nitty-gritty detail, and they say, look, this is what it is, and a lot of time you had to go back and say, look, let's look through this, and this is how we interpret this result or this technique. And they are different patients. You and this patient are very different. And so hopefully that's not a common occurrence now with patient going through a surgeon, and a lot of them are a discussion and managed so that it can come to a agreement before the surgery.
That'd be, yeah. In my experience, it's not so. Hopefully, in another few years, that might filter down. But at the moment, my experience as counselling them and counselling people with facial disfigurement or visible difference, that's not their experiences so far. Some of it is okay, but I mean, they're coming to the people, they're coming to have support, some social and emotional support, and sometimes the scarring has happened with trauma. It's been traumatic, and whether or not you have been a brilliant surgeon and done what you're the best, because what I'm hearing from you is there's lots of things that we don't see that you've got behind you thinking about X, Y, and Z and A, B, and C, which we don't see. And as you're saying, if we've reached the saturation point and the shutters have gone down and the birds, the brain has flown, you can't actually deal well. If we do it this way, these things are happening, but this is not going to get us to where we need to be, which is here. Because this is not negotiable with what we need to do next. It's
correct. I think in cancer it's less forgiving because they are time sensitive, and also a lot of things are determined by the cancer, and it is not something we can control. But I think what you might refer to are things that are negotiable. So like post-cancer treatment or a traumatic MVA or accident that happened, then from then
What's
on...
an NVA?
Well, MVA, motor vehicle accident.
Okay, right, yeah. Thank you.
Yeah. So those are not as time sensitive. So there are lots of room to discuss, and so if the patient reaches saturation, you can multiple discussion, because there's no time limit to when you need to act on those reconstructive or those to work that you needed to do. But cancer is very different. They are time sensitive, and sometimes we will have to guide their patient along and say, look, this is where if we delay that by another month, you're going to lose more of this function, and that's probably not in our best interest to do that. Now, ultimately, the patient will have to make that final decision.
What would you like the people to take away from this chat? What is the takeaway, do you reckon?
I think the takeaway is that you will want to work with a team. So the surgeon is not when I treat cancer, I'm not the only person treating the cancer. I'm treating it with a team. So it's my facial nurse. The facial nurse, we have a team. You do want to work with a team that you feel most comfortable to bring you through a journey, because none of these are one-off event. They are a journey that you're going to go through. Cancer is a journey of 5 to 10 years. Facial nurse is a journey of a lifetime.
Yes, yes, it is. Yes, it is. Okay, and with that, thank you very much for coming and answering some of those really curly questions, and I did it with some attitude because that was the attitude that was coming to me. So I gave it back to you. So thanks very much for being able to handle that with some finesse, and thank you very much for coming.
It's a pleasure. Thank you for the invitation.
Thank you. And
by golly gosh, it's the end of Karibu Anawim's 15 minutes at Dr. Zali's desk special. And that's a wrap for this episode. Thanks for tuning in. Please remember that all information given during this episode is for general application only. If you have any specific medical issues, as always, consult with your medical practitioner. Like, subscribe and share on whatever platform you find us on. For more information, please connect with Karibu Anawim on our website at karibuanawim.com or email us at inquiries@karibuanawim.com.